Hello. Good morning. Good afternoon. Am I audible to all of you?
Good afternoon, sir.
Good afternoon, dear. Okay.
Sir, it's audible.
Audible. Okay. You are also audible. I think, right. One of you can share your screen, ma. Who is going to start first? One of you can share your screen right now. Hello, is it audible? Friends, is it audible? John?
Sharath. Audible, Sharath. Priya here.
Okay, ma. Okay, ma. So, Priya, can you start sharing your screen? I mean, your presenter.
Yeah, he's
Be
yet
ready.
to join. I've just messaged him. Yeah, yet to join.
Okay, okay, okay.
Karthik. Sharath, shall I ask Karthik to share his screen?
No issues. No issues.
Yes, ma'am.
Can you share the screen, Karthik? Yeah.
Oh, 1 minute. Somebody else is sharing, sir.
No, not it. Somebody
John.
else. No, ma. John? Yes, it seems. John, are you trying to share? John, is it audible for you?
Yes, sir.
Okay, are you trying to share your screen? Are you trying to share your screen?
Yes, sir.
Okay, proceed for the presentation.
Can you see the screen, sir?
Yeah, go for the case presentation.
Okay, sir.
Yes.
Sir, sir, I'm audible.
Yeah,
Sir,
yeah, you are quite audible. Sir, good afternoon, sir.
Good afternoon. We are just only tested now.
Just and done, sir. We'll start by 2:30.
Yeah, you're there also. You have joined.
This is just a test run, sir. People
Yes,
are
sir. I
there.
joined, sir.
Carry on.
Okay, John, just go for the case presentation, dear.
Okay, sir. Thank you, sir.
Just show your slides and then,
Sir, my slide is visible, sir.
yes, you need to go into the slide. Your screen is visible. Your screen is visible. Go for the slide.
Now, sir.
Not it. Or else you stop sharing. Let me try with other candidates. You need to press the case presentation.
Okay.
You stop sharing right now.
Yes, sir.
Just give. Give stop sharing. Okay, then. Thank you. We have any other persons? Niranjan. Niranjan, are you there, my dear?
Yes, sir. Yes, sir.
Start sharing your screen, ma, because you are the first presenter.
Okay, sir.
Okay, done. Thank you. Okay. You have any audio video, ma?
No, sir. No audio video.
Okay, just scroll till the last slide. Done, dear. Stop sharing.
Okay, sir.
Okay. Be ready, na? Okay. And then Rishabh Burat. Are you there? Rishabh
Yes, sir.
Burat from See Here.
Yes, sir.
Yes, dear. Okay, okay then. Niranjan, stop sharing.
Yes. Yes, sir. Yes, sir.
Not yet.
1 minute, sir. Okay.
Okay. Right, Rishabh, can you start screening? Share your screen, please.
Yes, sir. So visible, sir?
Yes, go for the slideshow.
Visible, sir?
Okay, just scroll down till the end. While sharing, you need to. Okay, then. Thank you. Okay. Just log out. Stop screening your share. Okay, okay. Then we have Rishabh Burat. Okay. Toddler Sophia, we have done our presentation. And Niranjani, are you there, ma?
Yes, sir. Yes, sir. I'll share my screen.
Okay.
Where is it visible, sir?
1 second. Okay, then. Okay, then. Go for the slideshow, ma. Okay. Keynote.
Can I do it?
Okay, okay, okay. Done. Done. You have any videos? Niranjani, you have any videos?
Yes, sir.
Just
Yes,
see
sir.
whether it
It's
is
working,
clean.
sir.
Okay.
Yes, I have one video, sir. It's working.
Okay, it's working. Is it? Okay, okay. Niranjani, have you done with yours?
Yes, sir. I'm done, sir.
Okay, then. So you have stopped sharing, na?
Yes, sir. I stopped the sharing.
Okay, last one, Ilakya.
Yes, sir. I'll share.
Okay.
Visible, sir?
Done.
Yes, sir.
I think all of us have completed the test.
Excuse me, sir.
I can't get you.
This is Karthik from Apollo Children's Hospital, sir.
Karthik.
Second presentation, Sharad.
Okay. Just, yes, okay. Share your screen. Okay, done. Done.
Karthik, that video, can you just check?
Yes, ma'am.
அதான் அதிர்ஷ்டம் சாப்பிட்டாங்க.
Yeah.
Okay,
Play.
done.
Okay.
Share. Karthik, okay na?
Yes, sir.
Okay. Okay. Anyone? John? Are you ready right now? You had some problem with your screen sharing. John, are you there? John from Srihar, are you there, Pa? John, can you hear me?
Yeah.
Show me. Okay, done. Okay, John. Okay. Sophia, try.
Yes, sir. We have shared
Okay.
it. Can you see the screen?
Yeah, very well. Very much. Just stop sharing, ma. Sophia, can you share your screen?
Hello. Yeah, can you?
John, is your network okay? John, okay, it is visible. Just stop sharing now. John? Okay, thank you. We'll start by 2:30 sharp. Janani ma'am, you want to say something, ma'am? Is it audible and clear to all of you?
Yes, Sharath.
Okay, pa. So we have 2:20 right now. We have 10 more minutes. And this will be recorded in my computer. Soon we will be sending. Okay. This will be recording in my computer. Soon it will be uploaded in your YouTube and it will be shared. Sophia, are you there?
Yes, sir. Are you able to hear me, sir?
Yeah. You are quite audible. Share your screen.
Don't touch. Keep it like this.
Oh, sir. Sir, is it visible, sir?
Okay, done. Visible. Stop sharing now. Stop sharing. Visible. Thank you.
All the best.
Thank you.
Niranjan is presenting with the doctor. What is she presenting?
Hi.
Hello, sir.
Yes.
Sir, this is Rishabh here, pediatric
Who is
PG
there?
from Ramchandra. Rishabh, sir, from pediatric PG from Ramchandra.
Okay.
Srihar. So
Okay,
my
ma'am.
consultant has to leave a little earlier.
Okay.
Can I present first, sir?
Okay. Madam Janani ma'am, are
First
you
or
there,
second?
ma'am? Okay, no issues, ba.
Okay, sir. Thank
Okay,
you.
so you are presenting first.
Yes, sir.
And your case is on?
My case is on
Which
the
is
more you
your
look, the
case,
more you
dear?
see. It's fourth one in the list.
Fourth one. Okay, you be ready.
Yep.
Okay. Let's start with yours. No issues.
Okay, sir.
My consultant has video on when you want to take it. Hey, Sarath.
Hi, ma'am. Hi, ma'am.
Hey, sorry, நான் மெசேஜ் அனுப்பிச்சிருக்கேன் பாரு உனக்கு எனக்கு ஒரு டிஏஏபி வெபினார் இருக்கு இப்ப பேரலா.
பார்த்தேன் மேடம் இதெல்லாம்.
அதான் நான் வந்து ரெக்கார்டட் கேக்குறேன். வெங்கி will represent me.
Okay, madam. Okay, madam.
சரியா?
Okay. Fourth presentation from Srihar wanted to present first, ma'am.
பண்ணட்டும் no problem.
Okay, madam. Done.
Yeah, நீ ஆர்டர் அதுக்கு ஏத்த மாதிரி மாத்திக்கோ.
Okay, this will be recorded, madam. So don't worry, madam. Link will be sent.
Listen பண்ணு.
நான் அனுப்பி வைக்கிறேன்.
Thank you so much.
Okay, madam. Bye, madam.
Bye, Sarath. Thanks for all the last minute arrangements
No
and
issues.
help.
It's really our pleasure.
Yeah. Thank you. Until said otherwise, you will have to be the host.
No confusion. Okay.
Till next June.
Oh,
Till
right.
we resume to normalcy.
No issues. No issues.
Okay, bye.
Something, Sharath?
Sir?
Did you have your food?
Yes, sir. No issues, sir. One patient has brought, what is it, Adirasam today. So we had it.
Good.
Video on பண்ணி நான் இங்கே சாப்பிட்டு இருக்கேன். SB JAP ஓட வீடியோ ஆன் பண்ணி சாப்பிட்டு இருக்கேன். அம்மா நான் வந்துட்டேம்மா வீடியோ கூட ஆன் பண்ணிட்டேன். நான் பார்த்தேன் நீங்க சாப்பிடுறது அப்படின்னு. வீடியோ
I think we can share our link, no issues, to your friends or to any groups. We can accommodate almost 300 participants. So by 2:30, you can share the link to your friends or to any group, no issues. சொல்லு ராஜா. நான் ஒரு மீட்டிங்ல இருக்கேன், முடிச்சுட்டு பண்ணவா? முடிச்சுட்டு நான் பண்றேன். நான் மறந்துட்டனாலும் நீ 4:15 மணிக்கு எனக்கு call. ஓகேவா? சரி ராஜா. ஹலோ. Rishabh, you are going to start now?
Yes, sir.
Ready?
Yeah, ready, sir.
Wait, just wait a minute. So almost it is 2:30 right now. Let us start our Chennai City Pediatric Meet for the month of November 2020, and we have 7 interesting cases right now, and we need to thank our teachers and seniors for the opportunity given on behalf of our City Pediatric Meet team. And as per request, we are starting with Sri Ramachandra Medical College Institute. The case is, the more you look, the more you see, an unusual route to diagnosis. Presenter is Dr. Rishabh Burat, and it is from the team of Dr. Jabaraj, Dr. Mahesh Janardhanan. Okay, over to you, dear. Rishabh, the stage is yours.
Yeah. Yes, sir. Good afternoon, all. Good afternoon, all. I am Dr. Rishabh Burat, final year pediatric PG from Sri Ramachandra Institute of Medical Sciences. I'm going to present an interesting case titled as "The More You Look, the More You See: An Unusual Route to Diagnosis," under the guidance of Dr. Jabaraj, pediatric cardiologist, and Dr. Mahesh Janardhanan, pediatric rheumatologist, working in Srihar. Moving on to patient details. This is a 17-year-old female child hailing from Sivakasi, whose informant being mother and herself, and with reliable history, presented with a background history as follows. At 8 years of age, this child had fever with arthritis involving large joints on and off for the past 1 year, was diagnosed as probable rheumatic fever with carditis, had a mitral valve repair and a mitral valve replacement in the year of 2012 and 2013 in view of severe mitral valve regurgitation, was under follow-up up till last 1 year and was doing well, was on acetrom. Now presented with chief complaints of dyspnea for the past 2 months, palpitation for the past 1 month, and reduced urine output for the past 1 month. History of presenting illness: dyspnea for the past 2 months, gradual in onset, progressive in nature, was more on lying down and relieved on rest. There's history of palpitation for the past 1 month, which was progressive in nature, and history of abdominal fullness for the past 1 month, which was gradual in onset, progressive in nature, associated with poor appetite, and associated with reduced urine output. There was no history of chest pain, no history of fever, no history of facial puffiness, no history of syncope or hemoptysis or seizures or weakness of any limbs, no history of jaundice, no history of skin rash or swelling of any joints. She was treated at Sivakasi for her features of congestive cardiac failure and was found to have left ventricular false aneurysm. Family history: second child born of third degree consanguineous marriage, no history of any heart disease among the family members. Moving on to examination, child was conscious oriented. Pulse rate was found to be 110 per minute. Large volume pulse felt in the right radial artery. There was no radiofemoral there was no radial delay. The right femoral artery pulsations were found to be weak, probably secondary to the femoral arterial line placed in past for the past surgeries in the past. Her blood pressure was 90/60 in the right upper limb, and saturation was about was 96% in all 4 limbs. She also was found to have pallor and healed hyperpigmented lesions in both the lower limbs. The JVP was elevated. On cardiovascular system examination revealed a hyperdynamic apical impulse and pansystolic murmur at mitral area and a systolic murmur at tricuspid area. Liver was found to be enlarged with and was pulsatile and tender. Liver span was 13 centimeters. Moving on to investigations. So we'd done an echocardiograph for this child, which revealed a fistula from the left ventricle to the right atrium, a large left to right shunt, was suspected secondary to infective endocarditis. So this is the fistula, and we've marked it. And this is the left ventricle, and the fistula is running to the right atrium. And the lower down is the right ventricle. Moving on, this is the color Doppler showing the similar image with showing left to right shunt from left ventricle to the right atrium. And the cursor is pointing towards the same. It's pointing to the right atrium. So we planned for, we suspected this secondary to an infective endocarditis. So we planned for a cardiac catheterization to close this fistula. Fistula closure was planned, and for which we required an AV loop establishment as the device had to be passed from the venous side. We first initially attempted accessing the femoral artery, and we could not pass the guide wire beyond a certain point, and we found that the abdominal aorta was found to be blocked. So we completed this procedure by the right radial artery. So we passed the guide wire to the right radial artery into the aorta, into the LV, through the fistula. We parked the guide wire at the right atrium at the SVC opening. This is the guide wire. The cursor is pointing at the guide wire at the center. The central line. So then next we used this guide wire and snared it from the SVC into the IVC using a snare. The snare was passed through the femoral vein and hence completing an AV loop. This is the device being deployed through the femoral vein, and you see that the device is wider at the LV opening. And finally, we closed the fistula, and post closure, we did a echocardiograph, And this shows the pointer, the cursor is at the device, at the occluded device. During the procedure, we discovered the following: that there was an abdominal aortic occlusion, there was total occlusion of the right renal artery, there was significant left renal artery stenosis, and there was irregularity of the aortic lumen. So we had to reanalyze this case. Post-procedure, on details of the past history, we found that the arthritis was atypical and did not fit into the rheumatic fever. There was a rash involving both the lower limbs, which had occurred a year back and was suspected to be a pancreatitis. We missed certain following during examination. We missed that the bilateral femoral artery pulsations were feeble. There was a radiofemoral delay, and the lower limb BP were not recordable. We had done an ESR, which was 64 millimeters per hour, and we initially attributed to anemia. And now we were thinking in terms of an inflammation. Ultrasound abdomen was not done earlier. Post procedure, we had we had done an ultrasound abdomen and found that the right kidney was contracted, and there was a left renal artery stenosis. We had also done a CT scan, but which we had limited only to the chest. So the abdominal findings were totally missed, and the aortic calcification present was not given much of importance. This was the CT thorax with contrast showing aortic lumen calcifications. Hence, we focused on a probable underlying vasculitic phenomenon, thinking in terms of Takayasu arthritis. So we wanted to know if there's an active inflammation or is it a burnt out state. Hence, we wanted more evidence to the same, and hence cardiac MRI was planned. We chose MRI over CT angiograph because MRI determines the cardiac morphology and function better than, and it's a gold standard for cardiac morphology, cardiac function, and for the valve function. It is equivalent to tissue biopsy in terms of determining the tissue. So if there's presence of any edema or if there's any infiltrations. MRI also has high spatial and temporal resolution. There's no window issue, there's no ionizing radiation, and the contrast used has very few side effects. So this is the cardiac MRI, the sign images which are showing aortic wall irregularity and abdominal aortic occlusions. So the cursor is towards the irregularities of the aortic valve, and on the right side, the cursor is showing the abdominal aortic occlusion. This is the abdominal aorta and the iliac arteries, and these are the irregularities. And then we found that in T2 images there was aortic wall edema. They were hyper intense, and there was stenosis of the aorta, abdominal aorta. So this is the 3D reconstructed image, which shows occlusion of the abdominal aorta and left renal artery stenosis, severe stenosis. And there was an aneurysm noted in the not incompletely closed fistula note behind the left ventricle. This was another image depicting the marginal artery of Drummond, which was the major vascular supply for this patient. As you can see that there is abdominal aorta occlusion, and there's the cursor is running and pointing towards the marginal artery of the Drummond, and there's a pictorial image depicting the same. So finally, with the above history, clinical features and investigations, we diagnosed this case as Takayasu arthritis with an unusual complication of severe mitral regurgitation needing replacement, with a pseudoaneurysm probably secondary to Takayasu arthritis or an infective endocarditis, with occluded abdominal aorta, contracted right kidney with right renal artery occlusion and left renal artery stenosis. We managed this child with diuretics, oral anticoagulants, iron and calcium supplements. We planned to start this child upon corticosteroids, low dose methotrexate, and ATT as MANTO was positive. This child also requires abdominal aorta repair and auto transplant of the left kidney. Both have to be planned after the inflammation subsides. So moving on to Takayasu arteritis, it is a large vessel vasculitis primarily affecting the aorta and its primary branches. Females are predominantly affected aged 10 to 40 years of age group. The cell-mediated mechanisms are thought to be of primary pathogenesis. The inflammatory process can lead to narrowing, occlusion, or dilatation of the involved portions of the arteries. Clinical features. Symptoms are fever, weight loss, fatigue, claudication, arthralgia, abdominal pain, diarrhea, syncope, seizure, vertigo. Signs being absent or weak peripheral pulses, arterial bruit, and hypertension or difference in blood pressure of more than 10 millimeters of mercury. So this is the EULAR classification criteria, which says there has to be presence of arteriographic narrowing or occlusion of the entire aorta or its branches with at least one of the following: either claudication of the extremities or decreased peripheral artery pulsation, blood pressure difference of more than 10 millimeters of mercury, bruit over the aorta or its major branches, hypertension, elevated ESR or CRP. Cardiac involvement in Takayasu, with case reports, we found that aortic involvement occurs more commonly. Takayasu arteritis can also involve mitral valve. Mitral valve involvement is in the form of mitral regurgitation or stenosis, and mitral annular calcification have been reported in the past. These are the take-home messages. A thorough history and a complete physical examination in every patient supports investigations and help in diagnosis and management. Never ignore any findings, either examination or by investigation. For example, in this child, aortic calcification was missed. Aortic calcification is much more significant in children than in adults, but we missed it in this case. And even a well-established diagnosis may not be correct. So this child was an established case of rheumatic heart disease with mitral regurgitation, but turned out to be an unusual complication of Takayasu arteritis. So I would conclude with the metaphor saying every cloud has a silver lining, saying that if this patient hadn't turned up due to this fistula, this child would have ended up with total occlusion of the right renal artery and would presented with renal failure. Thank you.
Thank you. Thanks
These
for
are my
your good
references.
presentation. Okay, stop sharing. Participants, please post your questions in our chat box. Questions will be asked at the end of the session. Okay. You can stop sharing.
Now you can unmute.
Okay. Stop sharing. Questions will be at the end of the session. And the next case will be the devastating and fulminant encephalitic illness in a toddler due to unusual etiology. Presenter Arogya John, team Neurology and PICU, again Ramachandra Medical College. Start your presentation. Participants, please post your questions in chat box. Yes.
Good afternoon to everyone.
Go for slideshow. Go for slideshow.
Sir, my slide is visible.
Your slide is visible. Please go for slideshow.
It's already in slide.
Right, sir. Good afternoon to everyone.
It's in the slideshow mode only, Dr. Sharath. Maybe it's not coming at your end.
Okay, sir. No problem. Time is 8 minutes, ma. Try to complete within 8 minutes.
Sir?
Thank you. Try to complete within 8 minutes. Please proceed. You can start your presentation.
Yes, sir. Sure. Good afternoon to everyone. I'm presenting the case of. Okay.
I think the network on the side is not good. Are you there? John, are you there? John, are you there?
Yes, sir.
Network is not good, I think, from your side. Your audio, video, both are not clear. Okay. Try to do it right now. Okay, proceed.
Okay, sir.
Remove
this is
your
a case
mask.
of devastating and fulminant. Sorry. This is a case of devastating and fulminant encephalitic illness in a toddler due to unusual etiology. I am Dr. Aruki Jan, Junior Resident, Department of Pediatrics. This case is mentored by Dr. Shruti, Professor Shubha, Dr. Rajkumar and PICU team, and Dr. Ranjit Kumar Manogaran, our pediatric neurology from Srigar. Case details. The baby X, 18-month girl child, second born to non-consanguineous parentage, pre-morbid, developmentally normal, informant mother, reliability good, hailing from Tirupati with the complaints of fever for 10 days, inability to sit and stand for 10 days, and loss of head control for 10 days. History of presenting illness. Child had fever for 10 days associated with the difficulty in sit and stand from lying positions since day 3 of fever. Intermittent jerky movements on and off for 10 days. Child had persistent fever spikes with a deterioration in the neurological status, for which child was referred to SRMC for further management. Treatment wise, child was admitted and treated in day 3 of illness itself in local hospital. Birth history, antenatal, natal was uneven full. Postnatal, there was no NICU admission. Mother had exanthematous fever at 10th day of postnatal period. Child also had similar illness, managed conservatively. Prior to the illness, child was developmentally normal. Family history, no history of neurodegenerative disorder or epilepsy in the family members. General examination, no pallor icterus, no cyanosis clubbing, no lymphadenopathy, no fetal edema, no signs of vitamin deficiency, no exanthema, no dysmorphism, no neurocutaneous mark. This is a phenomenology which showed child had generalized myoclonic jerks. These events are suggestive of epileptic myoclonic jerks. Yes, sir. This is a myoclonic jerk movement. Anthropometry wise is normal. Systemic examination, CVS RS per abdomen is normal. CNS assumes a posture of comfort. Motor examination showed hypotonicity predominantly in the lower limb with the power of 2/5 with deep tendon reflexes are brisk. Clinical summary, a 18-month girl child presented with subacute febrile encephalopathy and acute neuroregression with recurrent epileptic myoclonus. We had a differential diagnosis like partially treated meningitis, viral encephalitis, demyelinative disorders, autoimmune encephalitis, and metabolic encephalopathy, unlikely CNS vasculitis and neurodegenerative disorders. Investigation, routine blood and CSF analysis were normal, infective workup are negative, autoimmune workup both serum and CSF are negative, including NMDA. This is a CBC showed at admission with lymphocytic predominant with mild anemia. The cultures were sterile, CSF cell counts and pathology and biochemistry were normal, viral panel negative. Intense flares in the bilateral frontal and right parietal white matter. This is a time compressed EEG epoch showed periodic epileptic changes suggestive of GPETs. It is seen in mostly in the variety of encephalitic illness, but most commonly seen in case of SSP. Management, in view of suspected meningitis, child was treated with broad spectrum jerks were treated by multiple anti-epileptic. In view of suspected autoimmune encephalitis, child was treated with the IV methylprednisolone with pulse therapy and IVIG. Pediatric neurology consultation was obtained. Clinical symptoms and EEG, MRI findings are suggestive of fulminant SSPE. The retrospective history of rash with fever at day 11 of postnatal life for both mother and baby. In view of high suspicion of measles, serum and CSF anti-measles antibody were advised. This is our ERA showed. Our ERA term came. The measles antibody both in CSF and serum was strongly positive. Hence, we made a diagnosis of acute pulmonary SSPE in a toddler due to measles infection occurred in the neonatal period. Pediatric neurologists advised to start AIMS protocol for SSPE. It consists of isoprenosin with intrathecal interferon alpha. The oral isoprenosin was started as per guidelines. Parents were not willing for intrathecal interferon. In prolonged ventilation, plan for to Tirupati GS were hometown, the tail jerks. Follow child had currently on oral isoprenosin with oral feeds and physiotherapy with the functional status scale of 18/90. Discussion. SSP is a slow virus disease caused by persistent mutant measles virus infection, usually occur after 6 years of age. It's a chronic progression, consists of multiple stages. The measles vaccines is not associated with increased risk of SSP. This is a video showed a 6-year child presented with neuroregressive milestones with myoclonic jerks. This is also a case of SSP, but it is a simple SSP. These are the stages of SSP. Stage 1 consists of irritability, dementia. Stage 2, various movement disorders. Stage 3 is extrapyramidal symptoms. Stage 4 is a loss of cortical function with the signs of vegetative state. The fulminant SSP is a rare presentation which the disease progresses to death over the period of 6 months. The features are atypical without passing through the various stages sequentially and it can be misleading. What are the risk factors for fulminant SSP? The exposure to the measles virus at an early age, the viral virulence and impaired host defense mechanism, derangement of T cell subsets, and concurrent infection with other viruses. This is a EEG findings of SSPE. There is a radar Michael complex will be present. The difference between simple form of SSP and fulminant SSPE, the age onset is 6 to 10 years. This is 1 to 6 months. Progressive mental decline with myoclonic jerks will be there. This is a atypical presentation. It affects both cases. Immunocompetent people will have higher risk. Inflammation and inclusions are higher in case of SSPE. The inclusions bodies will be very few in case of fulminant SSPE. Both types, the high titers of measles antibodies will be there. EEG showed periodic complex in SSPE, in atypical form in fulminant SSPE. MRI showed bilateral parieto-occipital white matter changes. In fulminant SSPE, it will be atypical. The outcome, SSPE will have a fatality rate within 1 to 2 years. The fulminant SSPE, the fatal rate within 1 to 6 months. Management is supportive care mainly, anti-epileptic therapy, antiviral agents like ribavirin, and immunomodulator like isoprenosin. This is the AIMS SSP treatment protocol. Our review of literature showed these are the cases of very early presentation of SSPE. In India, in North India, there are 2.5 years in Chandigarh, 26 to 27 months from Chandigarh. These are the early case presentation of SSPE, but no case reports of such very early presentation from South India. Conclusion, fulminant SSP should also be considered in patients having unexplained acute neurological presentation. EEG clues like GPET should make the clinician think of such differentials. In difficult case, sometimes revisiting the clinical history again may be rewarding. Thank you.
Okay. Thanks for the clear presentation. Audience, again requesting you to post your questions in our chat box so that it will be easy for us to ask those questions at the end of the session. Okay, stop sharing now. Okay. Now the third clinical case is a challenging case of combined central and peripheral demyelinating disease. Presenter Dr. Karthik Kumar from Apollo Children's Hospital. The team includes Dr. Mahesh and Dr. J.K. Reddy. Okay, stage is yours, Karthik. Start now. Karthik, you can start your presentation. You are not audible. Unmute yourself. You have not done it.
Yes, sir.
Okay, proceed now. Please stick to time, 8 minutes only.
Yes, sir.
Start.
Good evening, one and all. I'm Dr. Karthik Kumar, DNB PICU resident from Apollo Children's Hospital. I'm presenting on behalf of our PICU team, primary consultant Dr. Jaikumar Reddy and Dr. Mahesh Uzar, neurologist. This is the story of a smart little kid who presented in a very bad shape with combined central and peripheral demyelination, who stayed with us for 4 months and recovered remarkably well. Masavi, he was a 7 years old developmentally normal child who presented in a private hospital in Nellore with weakness of both lower limbs with pain for last 6 hours. There was no history of fever, no history of altered sensorium at the onset, no history of seizures, no history of trauma, recent vaccination, or bite. But he had history of URI 1 week back. He had flaccid weakness with areflexia, and over 12 hours, he rapidly worsened with involvement of upper limbs and bulbar muscle involvement. So he was promptly intubated for respiratory failure. So at the onset, he had acute flaccid ascending areflexic paralysis, which was diagnosed as Guillain-Barré syndrome, and he was treated with started with IV immunoglobulin. But unfortunately, over the next 36 hours, he developed altered sensorium with low-grade fever. Having ruled out all the correctable causes of altered sensorium, they went on to do MRI brain and CSF analysis, which were both normal. This is when he was referred to us for further evaluation and management. On arrival, he was tubed on bag and tube ventilation. Vitals were stable except mild tachycardia and hypertension. CNS examination was compatible with GBS, except that he was deeply comatose with GCS of 2T by 15, off sedation, and he had absent dorsal movement, which wasn't very much compatible with GBS. So we have a child with ascending flaccid paralysis with new onset altered sensorium and fever. So we went on to discuss about the differential diagnosis. The first differential was a fulminant GBS for the acute ascending areflexic paralysis. Second one was ADEM for the altered sensorium and weakness, but it could not explain the classical ascending weakness. Third one was Bickerstaff's encephalitis for the altered sensorium and bulbar weakness, but the limb weakness could not be explained. Since he had low-grade fever, we also considered acute meningoencephalitis, though it was lower down on the list. And he was considered for myasthenic crisis for the ophthalmoplegia with weakness. So once we did the emergency CT brain, which showed the severe cerebral edema. So we went on to do ICP catheter insertion, ICP monitoring, along with neuroprotective care, continuous EEG monitoring. Having received 2 grams per kg IV immunoglobulin, he was started on pulse methylprednisolone for suspected ADEM, along with antibiotics and antivirals, and we proceeded with etiological workup. CBC was normal, CRP was mildly elevated, urine protein cultures were sterile, HIV was negative, organ function tests were normal, serum electrolytes were normal. For myasthenic crisis, we sent anti-acetylcholine receptor antibody, and we started him on neostigmine test dose, which wasn't responsive, and acetylcholine receptor antibodies also came negative. There was no evidence of thymic hyperplasia or thymoma. New nerve conduction study was done, which was suggestive of acute inflammatory demyelinating polyneuropathy. So we had diagnostic thing for GBS, but still we could not explain the altered sensorium. So over the next 5 days, he was stabilized. ICP surges came down, ICP normalized, and with the ongoing treatment, there was ICP improvement, but weakness did not improve much. So we, after stabilization of ICP, we went on to do MRI brain with spine. MRI showed acute hemorrhagic leukoencephalitis, which is a severe form of ADEM, and MRI spine was normal. So now we have 2 diagnoses: acute hemorrhagic leukoencephalitis, which is a form of ADEM, and AIDP, which is a form of GBS. This is the MRI picture showing multiple punctate hemorrhagic foci in the corpus callosum and subcortical white matter. This is diagnostic of acute hemorrhagic leukoencephalitis. Further evaluation was done. After 1 week, CSF analysis was done, with basic biochemistry was essentially normal with proteins of 40, except RBCs was around 100. CSF was sterile. Meningoencephalitis panel was negative. CSF gangliosides for GBS workup were negative, including GQ1B antibodies. CSF autoimmune encephalitis panel was negative. Other investigations included Mycoplasma pneumonia IgM, which was surprisingly positive. Lyme serology was negative, respiratory panel for bacteria and viruses were negative, and B12 level was normal. So we went on to treat him with IV azithromycin for 7 days, and after 2 weeks of IVAG, he received 7 cycles of plasmapheresis. So he stayed with us for 4 months, and he was considered for early tracheostomy, and it was done on the start of the 2nd week. He had severe autonomic instability. He had poor cough, and because of that, he had recurrent collapse and VAP. He required regular bronchoscopic airway toileting. With good physiotherapy, his weakness slowly improved over 3 months. With supports of orthotic splints and the cough assist device, we were slowly able to wean him off ventilator, and tracheostomy was decannulated. This was the discharge status. He was discharged after 4 months after 117 days of ventilation. He was completely, GCS was normal. 15 by 15, he was vocalizing and handling secretions well. He was standing with support with mild hypotonia. Power was 4 by 5 in upper limbs, and lower limbs it was 3 by 5 and gradually improving. This is the current status. We could see the child happily riding a bicycle. Now it's been around 5 months post discharge. So now we have this child. In this case, we have a central demyelination, which is acute hemorrhagic leukoencephalitis. We have a peripheral demyelination, which is AIDP, with possible etiology being secondary to Mycoplasma pneumonia. So let's see a few things about notable points in this case. Acute hemorrhagic leukoencephalitis. It's an inflammatory hemorrhagic demyelination of CNS white matter. It's considered to be an hyperacute variant of ADEM. It's more rapidly progressive. It's more severe than typical ADEM. Though the symptomatology is similar, the prognosis is very bad. It typically follows an URTA, like in our case. A brain MRI reveals multifocal hemorrhages. CSF usually has white and red blood cells. In our child, we had RBCs around 100 with increased protein concentration. Prognosis is bad as well. So the first thing that came to our mind when this child came was, why is this child with the classical history of GBS has altered syndrome? So can GBS and ADEM occur simultaneously? So there are few scattered case reports where they have documented simultaneous GBS and ADEM. This is a case series of 4 cases where either GBS is followed by ADEM or ADEM is followed by GBS. This is another case series where around 30 patients with overlapping demyelinating disorders were described. So based on this scattered case reports, recently a recent term has been coined where it's called combined central and peripheral demyelination. These are autoimmune disorders affecting both the central and peripheral nervous system, occurs either simultaneously or within a short interval. In our case, it was to start with, it was GBS, and within a short interval, child had developed ADEM. This might be due to a common trigger, and it might be due to a common target like neurophasin. The treatment response is variable, and there is no conclusive diagnostic criteria for this CCPD. How frequent is mycoplasma associated demyelination? Extra respiratory manifestations in mycoplasma is around 25%, but nervous system contributing around 5%. Aseptic meningitis, GBS, encephalitis, cerebellar ataxia are common, though ADEM is rare. Interestingly, Mycoplasma pneumonia is the second most common infectious cause for GBS after Campylobacter jejuni. Remember, respiratory infection can be totally asymptomatic, and the child can directly land up with neural complications. The pathomechanisms include direct, where the Mycoplasma pneumonia directly invades the brain and causes the damage, indirect, like in autoimmunity, and vascular varicose, where it can cause stroke. This autoimmunity is because of galactocerebrocyte cross-reactivity. The diagnosis is by Mycoplasma pneumonia serology, CSF IgM, and CSF DNA. Treatment is by macrolides, tetracyclines, and fluoroquinolones. Depending upon the CNS manifestation, we choose the immunomodulation like IVAG, plasmapheresis, or steroids. The take-home messages include CCPD is a newly recognized entity. Do consider it in a child with flaccid weakness and altered sensorium. Demyelination in association with prior respiratory tract symptoms should prompt us to investigate for Mycoplasma pneumonia. Remarkable recovery is possible like in our child, even with fulminant neurological disorders. Prompt PICU management, perseverance, patience, personalized multidisciplinary care are the key to success. A big thank you from our team of consultants and fellows, and a big shout out to all the nursing staff, physiotherapists, and other specialty consultants involved in this. Thank you.
Thank you, Karthi. Thank you for a very good presentation. Okay, have you stopped the sharing? Okay,
Yes,
dear. Questions, you have some questions, but it will be asked only at the end of the session. And now the fourth presentation is from KKCTH under Dr. SBS Sir Unit, and presenter is Dr. Niranjan. Niranjan, the stage is yours. Niranjan, you okay?
Yes, sir.
Okay. Slideshow, start presenting. Stick to time.
Good afternoon, everybody. I'll be discussing an interesting case with the title of an unusual manifestation of an innocuous bug. This is Dr. Niranjan Hegde, is DNB Junior Resident in Child Trust Hospital. This is the details of a 3.5-month-old male infant who was previously well and developmentally normal, and the baby was exclusively breastfed. The baby presented with the history of high-grade intermittent fever for the 5 days. The maximum temperature recorded was 103 degree Fahrenheit, with associated with the inconsolable cry, irritability, and refusal of feeds for the past 3 days. And the parents consulted a local doctor who prescribed cefixime, which was given by the parents for 2 days. But there was, in fact, worsening of the symptoms. So the child was brought to our hospital for the further evaluation and management. Mother also mentions the history of watery diarrhea for 2 days, 1 week prior to the onset of the current febrile illness. When we received the child in our OPD, child was very sick looking, toxic looking, and on general physical examination, we found that the anterior fontanelle was bulging, tense, and the child was very irritable. The child was continuously, incessantly crying. However, child was hemodynamically stable, and there was no focal neurological deficit when we examined the child, and other systems were normal. Other systemic examination was normal. So, in view of irritability, high-grade fever spikes, refusal of feeds, and bulging anterior fontanelle, our first clinical diagnosis was pyogenic meningitis with sepsis probably. So we did the baseline blood investigations, and blood and CSF cultures were taken. We empirically started the child on ceftriaxone and vancomycin. This is the basic blood investigation picture. Our CBC showed hemoglobin of 10.4 gram per deciliter. Overall, in the CBC, there were high counts with neutrophilic predominant, 77% of neutrophils, and higher platelet count of 5.2 lakhs, and CRP was very high, 179 milligram per liter. CSF picture showed the total leukocyte count of 96 per cubic millimeter, out of which 40% were neutrophils and lymphocytes were 60%. Protein were high, 302 milligram per deciliter, and strikingly sugar was just single digit 1 milligram per deciliter. Next day, that's the 24 hours after sending the culture, our microbiology team informed us that the CSF and blood both are growing gram-negative bacilli. Child was still sick looking, spiking high-grade fevers, so we escalated the antibiotic to meropenem. Since we got the GNB, we stopped vancomycin. Within the next 24 hours, we received the final culture report from our microbiology lab, and they said it's non-typhoidal Salmonella species in both blood and CSF. Fortunately, we were pan-sensitive, sensitive to cephalosporins. So we de-escalated the antibiotic to ceftriaxone. This is the sensitivity pattern. Now we got the bug, we got the sensitivity pattern, we got almost our final diagnosis. So we were quite confident in treating the child with only ceftriaxone. And this is the fever spike during our inpatient course of our patient. So by day 5 of illness, the fever somewhat started settling down, but the child through 2 episodes of multifocal seizures, each lasting for around 5 minutes, in the form of uprolling of eyes, stiffening of the body, and unresponsiveness during the ictal phase. And there was no focal neurological deficit during the post-ictal phase, and we checked for the blood sugar levels, which was normal, electrolytes were normal. So we stabilized the child during the seizure ictal phase, and we started the child on levetiracetam. So these were the possibilities we thought during when the child through the seizures. We thought of what if it's the complication of meningitis like abscess formation, or what if it is cerebritis, ventriculitis, infarctions, or electrolyte imbalance, mostly secondary to SIADH or cerebral salt wasting, or rarely if it is because of neuroglycopenia. So to look for the complications, we went ahead with the MRI imaging of the brain. So we found that there was significant meningeal enhancement in the contrast enhanced picture, and we also found that there is a localized collection in the interhemispheric region, particularly in the high frontoparietal region. Most probably there was an early abscess formation, but the abscess did not show any mass effect, and it was quite in an inaccessible area, difficult to access area. So we plan to continue conservative management for the child with daily measurement of head circumferences, weight gain, and closely monitoring for the focal neurological deficits and vital parameters. By day 6 onwards, of the fever almost settled, we continued on ceftriaxones. We continued to monitor the child, and by the second week onwards, child became totally symptom-free. Like the oral intake improved, irritability reduced, the activity improved, and the child started to gain weight. And we did a repeat blood culture. The repeat blood culture was sterile. Being an unusual manifestation, we did a primary immunodeficiency workup also. In the CBC, the absolute neutrophil count was normal, absolute leukocyte count was normal, and the TB NK cell flow cytometry was also normal. Immunoglobulin profile was normal, and the workup for chronic granulomatous disease, that is NBT, was negative, and the MSMD workup has have also been sent, whose report is awaited. So during the hospital stay, child did not have any further seizures, and child received antibiotic, sensitive antibiotic, that is ceftriaxone, for a total of 4 weeks. We gave the injection vitamin K every fortnightly. We got an hospital evaluation also done, which was normal, and we got a BERA done, which showed a good hearing function bilaterally. And prior to the discharge, child also received age-appropriate vaccinations. So what were our limitations? What we didn't do were source of infection for this child who was exclusively breastfed. We couldn't trace the source. We didn't do the stool cultures of the parents or the family members, and also we didn't try to look for the strain of the non-typhoidal salmonella due to various financial constraints and social reasons. So going to some literature review, if we look for the sources of non-typhoidal salmonella, the most common sources are the animals, particularly the animals which we eat, like poultry, pigs and cattle, and also the pet animals like cats, dogs, birds and reptiles. They have these non-typhoidal salmonella running all the time in their guts. So they are the most common sources of non-typhoidal salmonella infection. And following after that, undercooked eggs are also considered a very important vehicles for the infection. Particularly, it is said that when there is no outbreak of non-typhoidal salmonella infection, the most common sources are the undercooked eggs, particularly these half-boiled eggs, half-boiled omelets. And also, the person-to-person transmission can occur. If one family member is infected with the salmonella, he can spread the infection to the other family members also. Briefly explaining the pathogenesis of non-typhoidal salmonella, the most important part is the non-typhoidal salmonella has a secretory system called as type 3 secretory system, and they secrete 2 types of proteins called as SPI1 and SPI2. SPI stands for Salmonella pathogenesis island and protein 1 and 2. When the organisms infect the humans, they secrete these proteins into the host cells. The main function of SPI1 is to facilitate the organisms to modify, to alter the host immune system, and to help in the diarrheal disease, help in the formation of diarrheal disease. Once the organisms enter the host cells, they also secrete this SPI2. The main function of SPI2 is to protect the organisms being digested by the host cell digestive enzymes, particularly lysosomal enzymes. So when the macrophages, they ingest the phagosome, the bacteria, due to the influence of SPI2, protective capsule is formed called as salmonella containing vesicle. This salmonella containing vesicle, it acts as a protective vesicle inside the host cells, particularly macrophages, and help the organisms to stay very longer inside the host cells, unlike other organisms. This is the most important part of pathogenesis. These SPI2, they help in help the organisms to stay for longer time in the host cells. So what are the clinical syndromes with which non-typhoidal salmonella can present? The most common is the acute enteritis, which is seen in the children, particularly under 5 age group. And the second other manifestations are bacteremia, occult bacteremia. Particularly in the susceptible individuals, the occult bacteremia can occur very commonly. And recently it has been found that there is a resurgence in, there is increase in the incidence of occult bacteremia due to non-typhoidal salmonella in African people. And mostly the exact reason is unknown. Mostly it is attributed to common HIV infection in the African people. And other manifestations are invasive focal infections like encephalitis, like meningitis, osteomyelitis, septic arthritis, encephalitis, etc. And chronic carrier stage. It is well known that salmonella in adults can result in a chronic carrier stage, staying inside the gallbladder. But it has also been found that even non-typhoidal salmonella infection, it can even that non-typhoidal salmonella can also result in chronic carrier stage. And paradoxically, this chronic carrier stage is seen more commonly in young children. Even the infants, they can continue secreting non-typhoidal salmonella as long as 5 years after getting an infection. And one more paradoxical thing is whenever the non-typhoidal salmonella is treated with antibiotics in hosts in whom there is no risk factor for an invasive disease, it is known to cause increased excretion of bacteria from the gut and known to cause a chronic carrier stage in those individuals. So treating non-typhoidal salmonella enteritis is known to result in a chronic carrier stage. So the main principles of management, whom we have to treat the non-typhoidal salmonella diarrhea. The young infants, particularly less than 3 to 6 months of age, it is prudent to treat non-typhoidal salmonella. And those with HIV or AIDS, those with primary immunodeficiencies, or those children who are on immunosuppressive treatment, those with leukemias or lymphomas, those with hemolytic anemias, sickle cell anemias, and those who are severely undernourished, and those with asthenia. These are the risk factors in whom the treating non-typhoidal salmonella is justified. Non-typhoidal salmonella diarrhea is justified. And coming to the point, why the young infants are more susceptible to the both invasive as well as diarrheal disease by non-typhoidal salmonella.
Already it is 15 minutes, dear. Make it crisp. I'm sorry.
Okay, sir. So the most common mechanisms which are explained are rapid gastric emptying, which are seen in young infants, relative achlorohydria, a poorly developed cell-mediated immunity, and a relatively immature complement system. How to treat the non-typhoidal salmonella invasive disease, particularly meningitis. So it's an intracellular pathogen, we all know, and I have explained why it can remain for a longer duration in the macrophages in the host cells. So we have to treat the children for a longer duration, particularly at least for 4 to 6 weeks. And particularly in meningitis, the bacteria can stay in the reticular endothelial system in the central nervous system for at least 2 to 3 weeks, and the CSF can be absolutely sterile despite these organisms staying inside the cells. So uncomplicated meningitis, it is recommended to treat 4 to 6 weeks, and with any other complications, the treatment has to be further prolonged, like 8 to 12 weeks. It's all based on the clinical judgment. So most commonly used antibiotics are ceftriaxone or cefotaxime as a monotherapy is the most common recommended. and carbapenems are drugs reserved for the resistant bugs. So take-home messages. We have to be very cautious in OP basis antibiotic treatment for young infants with fever without localizing signs. The clinician should be very vigilant enough to pick up the subtle signs and symptoms the infants present with the very sinister diseases. And non-typhoidal salmonella infection in young infants and immunocompromised children need antibiotic treatment, unlike gastroenteritis in other age group children who are not having any other risk factors. And invasive non-typhoidal salmonella infection is not so uncommon among under 5 children, particularly in infancy. Meningitis should be treated with the appropriate antibiotics for at least 4 to 6 weeks duration. Third generation cephalosporin are the most recommended drugs, and monotherapy is recommended. Children have to be followed up very closely and regularly for the sequel of meningitis. Thank you.
Thank you, dear. Thank you. Okay, questions will be again at the end of the session. Okay, stay there. Okay, and the fifth case will be stop sharing.
Yes, sir.
Okay, and thank you. And the fifth case will be from Department of Pulmonology, ICH Igmore, by Dr. Sophia. The case is a toddler with anemia and the diagnostic dilemma. Sophia, you are invited to the stage. Sophia, are you there? Okay.
Yes, sir. Is it visible, sir?
Okay, visible, visible. Visible, audible, proceed.
Okay, sir. Good afternoon, everyone. Myself, Dr. Shobhya, is an cause of anemia on behalf of pulmonology team. A 1-year-old male child, second born out of a non-consanguineous marriage, a developmentally normal child, presented with a complaint of increasing paleness over the past 10 days. Child was apparently normal till 1 year of age and then developed increasing paleness, which was noticed by the mother over the past 10 days. There was no history of hematemesis, melena, or other bleeding manifestation. There was no history of drug intake. There was no history of pica or passing wounds in stools. No history of cough, fever, or breathlessness. And past history, there were no history of similar complaints in the past and no previous admissions. Antenatal, natal, and developmental history was normal. There was a significant contact history of pulmonary tuberculosis in uncle who was on ATT 6 months back. On examination, there was severe pallor, but there was no icterus or hepatosplenomegaly suggestive of hemolysis, no signs of CCF. And on basic investigations, HP was 2.3, which was a severe anemia with a microcytic hypochromic picture with a raised RDW, which was suggestive of an iron deficiency anemia. And in biochemistry, the renal and liver function tests were normal. So for anemia workup, there was a significant finding of corrected retic count, which was 0.3, which was low, and an IgM parvovirus was positive. Rest of the workup was normal. And on admission, the chest X-ray was done, which showed an incidental finding of right lower lobe pneumonitis. And with a contact history of TB, it gave a course of antibiotics. And after the course of antibiotics, it was worsening, and still there was a persistent patch. And due to suspicion of TB, we proceeded with CT. And it showed necrotizing consolidation of right upper lobe with cavitation with right paratracheal lymphadenopathy, which was suggestive of pulmonary tuberculosis. So TB workup showed MAN2 positivity, and there was no evidence of, no microbiological evidence of MTB in RGJ as well as in specimens. So we had two issues. One was a sudden onset anemia with no evidence of hemolysis with an IgM parvovirus positivity with the presence of an abnormally low reticulocyte count. It was a probable parvovirus-induced red cell aplasia was thought of, and PRBC transfusion was given, and child was started on oral iron supplements. Next was an incidentally diagnosed right lobe pneumonitis with a contact PTB and a MAN2 positivity with a CT chest suggestive of TB with cavity and a bowel specimen showing cheesy material. But though there was no microbiological evidence, child was started on ATT on a clinical basis and also on steroids due to suspicion of endobronchial TB. And after 6 months of ATT, child was followed up, and repeat X-ray was normal, and repeat hemoglobin was 6.7 despite well-tolerated oral iron supplements. So 1 month after completing ATT, child again presented with dyspnea, with hemoptysis and hypoxia. This time the HB was 4.8 with chest X-ray showing diffuse bilateral infiltrates, and hence we proceeded with bilateral, CT chest, and it showed bilateral ground glass opacities. Due to the triad of sudden onset failure with severe respiratory distress and hypoxia, probability of pulmonary hemosiderosis was thought of, and we proceeded with BAL. And this time, cytology revealed 80% hemosiderin-laden macrophages, which was suggestive of pulmonary hemosiderosis. Still, we had to rule out vasculitic and other common causes of pulmonary hemosiderosis. Since the child was sick, we started on IV methylprednisolone, and workup for vasculitic and other causes were sent, and child was discharged and kept on follow-up. So the workup for other vasculitic and other causes, celiac disease was normal. The cow milk protein allergy, IgE cow milk protein was again normal. For SLE, Goodpasture syndrome and microscopic polyangiitis, all levels were normal. The only significant finding was C-ANCA positivity, which was suggestive of granulomatosis with polyangiitis. So we looked for renal involvement. The urine spot PCR and urine routine was normal. So according to the new EULA criteria for pediatric onset granulomatosis with polyangiitis, the child fit in two criteria. One was the C-ANCA positivity, another was a cavitating lesion on chest imaging. This was found prior to starting ATT, but though there was no fever and also there was no microbiological evidence of pulmonary tuberculosis. So that could have been attributed to granulomatosis with polyangiitis of pediatric onset. So the child had a score of 7 by 10, a score more than 5 by 10 favors granulomatosis with polyangiitis. But the points against GPA was the age of the child. The median age is around 11, but the child's age was 1 year, and there was no fever or no other systemic manifestations like upper airway involvement and renal involvement. So there have been, we looked at the literature, there have been case series with isolated pulmonary involvement with no renal or upper airway involvement, and it had presented with the case series had asymptomatic pulmonary lesions to a dramatic life-threatening clinical presentation such as diffuse alveolar hemorrhage, as in this case. So pediatric onset GPA, the incidence is 1 in 1 lakh, and this is the first case of pediatric onset granulomatosis with polyangiitis in ICH for the past 10 years. The pathogenesis is the polymorphisms in interleukin-10 and alpha-1 antitrypsin, which predisposes to ANCA-mediated activation of pro-inflammatory pathway. So the treatment plan for this child is a remission induction with injection pulse methylprednisolone with cyclophosphamide, and maintenance therapy with methotrexate or azathioprine weekly up to 1.5 to 2 years. And in refractory cases, we can try rituximab. In case of airway granuloma, intraarterial steroid plus with endoscopic dilatation could be tried. PCP prophylaxis is indicated in any case who's on cyclophosphamide, methotrexate, or rituximab. So the take-home message is any case with disproportionate anemia with pulmonary infiltrates, think about the possibility of pulmonary hemorrhage. Thank you.
Okay. Thanks for your fast presentation, and you are on time. Again, stay there. Questions will be at the end of the session. Stop sharing your screen, please. Stop sharing. Okay, thank you. And the penultimate case scenario is migrating foreign body. Online classes tragedy during COVID-19. Presenter Dr. Niranjani, again from Srihar Ramachandra Medical. Niranjani, you are invited to speak.
Yes, sir.
Yeah. Share your presentation.
Sir, my screen is, am I audible? Yes, sir. Are you able to see the slides, sir?
No.
Sir, am I audible?
Yeah, your slides are visible. You are audible and visible.
Sir, am I audible?
Yes, you are audible and visible. No issues. Okay. Proceed.
Okay, sir. Good afternoon, all. This is Niranjani, first year pediatric PG from Srihar. I'm presenting a topic on migrating foreign body, online class ordeal during COVID-19 under Professor Rajkumar sir and PICU team. History, 7-year-old boy. Sir, can I go ahead, sir? There was some audio disturbance in between.
Yeah, proceed.
See, a 7-year-old boy was attending online classes alone in his house. Suddenly came to the mother with breathing difficulty. The child was anxious and couldn't speak. After which he became unresponsive with stiffness of limbs for 2 minutes. After regaining consciousness at home, the child keeping the cap of the microtip lead box in his mouth while listening to the cloud, and he accidentally swallowed the foreign body. So he swallowed the cap of the lead box. After failed home remedies, the child was taken to the nearby nursing home. X-ray neck and chest was done, which showed no obvious foreign body. Hence, the child was reassured and sent home. Since the child complained of left-sided chest pain, they came to SRMC ER. At ER, airway was patent, breathing, respiratory rate around 26 per minute, saturation was 93% in room air, and reduced air entry on left side. Circulation, heart rate was around 95 beats per minute, no signs of shock. Disability, child was conscious and oriented. Child was afebrile. Otherwise, rest of the examination was normal. Chest X-ray was done, which showed left lower lobe collapse with consolidation, as shown in the image. Course in the hospital, child was immediately shifted to the OT for emergency rigid bronchoscopy. Foreign body was visualized at the left segmental bronchus of lower lobe. Multiple attempts were made to retrieve the foreign body, but there was slippage, and after some time, the foreign body was not visualized. After which the child was shifted to PICU, intubated. Child was maintaining saturation with minimal ventilation settings. This is a post-procedure X-ray. In comparison to the previous X-ray, we can see that the left inflation is better now. CT thorax with virtual bronchogram was planned for this child, which showed no obvious foreign body in the bronchi, but could have possibly be located in one of the segmental bronchi of left lower lobe, corresponding to the initial chest X-ray done. Also, there was another finding, cylindrical dilatation of the posterior basal segment bronchus of the right lower lobe was present because of a large mucus plug. After which the child was extubated, came off oxygen. The child complained of right-sided chest pain post-extubation. Clinically, the child was stable. Left lung expansion was good. Air entry was equal on both the sides. The plastic foreign body was not visualized both on chest X-ray and CT. We were confused in view of it being a radio opaque object. It was not visualized radiologically, and but with the bronchoscope, they were able to see in the left segmental bronchus. Hence, we actually asked the mother, since she had a duplicate similar microtip pencil box at home, we asked her to bring her the foreign body again, and we placed the duplicate foreign body in the child's right forearm, which actually showed, in contrast to our thinking, only the outline of the foreign body was radio opaque, otherwise it was radiolucent. So the possible reasons why it was not visualized on the chest X-ray could be, one reason being that the lumen of the foreign body was hollow, so it could have coincided with the wall of the bronchus and hence not visible. Or the other reason being the density of the foreign body could have corresponded to the atelectasis of the lung. Since we were not able to localize the foreign body radiologically, flexible bronchoscopy was done. So as we can see in this video, with the fiber-optic bronchoscope, we are entering the right bronchus and segmental bronchus as it follows. So foreign body is visualized in the lower lobe segmental bronchus. So with this, we infer that the foreign body has been migrated from the left lower lobe, which was the initial finding from the rigid bronchoscopy. It's now migrated to the right segmental bronchus, and retrieval attempts were made with the fiber-optic bronchoscope, but was not successful. Reason being, as we can see, with the lumen, only a part of the rim was visible. The other part was being embedded within the mucus of the lung. Hence, it was not be able to retrieve. Then the child was planned for repeat rigid bronchoscopy in OT, and again attempts of foreign body was done, which was not successful. Finally, right thoracotomy was done. Foreign body was visualized through the lung parenchyma very superficially, and hence incision was made and the foreign body was removed and it was sutured. This is the post-operative X-ray, which shows both the lungs are well expanded post-extubation. After course of antibiotics, child was discharged. Discussion from this case would be almost 75% of the foreign body aspiration usually is under less than 3 years of age. However, more than 3 years of age, where the foreign body aspiration happens, usually it's when the child is playing and it's associated with more complications. And most of the common foreign body which are aspirated are organic foreign bodies like groundnut, followed by inorganic foreign body like toy parts or pen caps being incidence of 15%. Next, there's a recent report published in Archives of Childhood Diseases, which shows there's a surge and increase of domestic incidents. This, as you can see in the graph, it's in comparison with 2019 and 2020. So the overall general pediatric cases have significantly come down in comparison with 2019 in view of COVID. Whereas the domestic incidents such as trauma, poisoning, burns, and foreign body aspiration, as you can see in the graph, there's been a surge increase in the cases of domestic accidents in 2020 compared to 2019. The questions would be, why was the foreign body not seen in chest X-ray? As explained before, two possible reasons being the lumen coinciding with the bronchial wall, and also the density of the foreign body in similar to the atelectic lung. The other question being, this child had a peculiar symptom of chest pain with the foreign body aspiration, which is not a very presenting symptom of foreign body aspirations like cough, choking, or breathlessness. There could be possibly two reasons. First reason being bronchial inflammation itself can cause the chest pain. And second reason, because of the foreign body close proximity to the pleura, could have resulted in the pleuritic chest pain, and it corresponded according to the migration of the foreign body in this specific case. Learning points would be, history of aspiration associated with significant clinical presentation, one should completely evaluate before reassuring. Even if the foreign body is radiopaque, sometimes it cannot be visualized radiologically. And when in doubt, we should always do flexible bronchoscopy for diagnostic purpose. And migration of the foreign body is reported very commonly. And in complicated cases like this, we need a multidisciplinary approach involving pediatric surgery, pulmonology, PICU, and general pediatrics. COVID pandemic and online classes can cause unusual clinical problems. These are my references. Acknowledgement. I would like to thank PICU, Pediatric Surgery, Radiology, Pulmonology, and team. Thank you for giving me this opportunity.
Thank you, Ma. Stop sharing. Okay. And the last case will be an interesting case of altered bowel habits with leaky kidneys from Dr. M. Viswanathan, Apollo Children's Hospital, by the presenter, Dr. Ilakya. Ilakya, over to you.
Thank you for all being here today. I'm Dr. Ilakya from Apollo Children's. I'm here to talk about an interesting case of altered bowel habits with leaky kidney. This is a 5-year-old, 6-month-old girl was brought with a complaint of abdominal pain for 2 months and associated with diarrhea, blood and stool with mucus for 15 days. And vomiting and low-grade fever for 1 week before presenting to the hospital. Other vitals and physical examinations were normal except the poor weight gain. We just went off with a basic investigation and ESR was elevated, others were normal. Renal and liver functions were within the limit. According to this age and associated symptoms, we just worked out with and ruled out our infectious etiology, immune and other GI pathology. thing was turned out to be negative. So we later on we went with a fecal calprotein that is increased around like 912. So with this thing, we just went with a colonoscopy where it showed a patchy pancolitis predominantly on the right side. The same histopathology also revealed it with eosinophilia. The age of onset with the symptoms and signs, we diagnosed this child as a very early onset inflammatory bowel disease. So we slides some. So with the proper enteral nutrition, we started the baby with the 5-aminosalicylate mesalamine, and she responded well to these medications and she attained a remission after 6 months. She was on continued medications and we were following the baby with a regular and with the biochemical reports were within the range. So this is the thing, and again we were following, like after 2 years later, she presented with a new complaint of fever and cold for 4 days and followed by generalized swelling of the body for the next 3 days. The swelling started from the face and followed by abdomen and lower extremities. There is no associated rash, sore throat or fast breathing. And we just went to clinical examination where anthropometry measures were normal, vitals were within the range, head to toe examination revealed no significant changes. On systemic examination, per abdomen showed soft, non-tender, distended abdomen with no specific organomegaly. Other systemic examinations were normal. Extremities showed edema and skin and neurological examination were within limits. So we went off with the basic investigations were complete blood count revealed normal and liver function test showed hypoalbuminemia. Other than that, other reports were normal. Renal function and electrolytes were within range. Ultrasound abdomen showed mild hepatosplenomegaly with insignificant features, and ultrasound KB showed unremarkable changes. The specific test we done for the etiology where there is an increased hypercholesterolemia and hypertriglyceridemia and massive proteinuria, and other complements and ASO titers were negative. With this clinical signs and symptoms and lab parameters, we know like it is a massive proteinuria, hypoalbuminemia, edema, and hypercholesterolemia. I know this is a nephrotic syndrome, which is probably a minimal change disease. So as it already know, like albumin was just only 2 for this baby. We started with albumin infusion and followed by we started with a full course oral steroids. Baby was well responded and discharged on the 3rd day. After completion of full course of oral prednisolone, and after 3 weeks later, again the baby presented with persistent proteinuria with the same signs and symptoms. So we started with oral prednisolone with a full course and a proper dosage, and after completion of this, again at 4 weeks of later, the baby again presented the second relapse. Same thing was happened, and this is the 3rd relapse the way it was happened for this baby after completion of the oral prednisolone. This is the when the 3rd relapse happened, the baby was in West Bengal, so we couldn't able to consult the baby in person. So we consulted via like telemedicine, and we approached the parents to come back, and we approached for this renal biopsy, and also the baby has also had a history of 3 years later, like very early onset IBD. So we just want to rule out whether the disease is active, ongoing active process is going on, or is just only a renal disease. So they came back and we just went off with the colonoscopy and as well as a gastroscopy, and still there is a mild to moderate colitis is present. So there was a frequent relapse nephrotic syndrome and also a steroid dependent nephrotic syndrome. So we just went off with a renal biopsy and it came as a minimal change nephropathy, and immunofluorescence turned out to be negative. So here, like, I'm not going to detailedly express about your IBD or a minimal change nephropathy. There is an association. Initially, the child presented with IBD and followed by minimal change nephropathy. Either what could be the possibilities? Either the drug which is used to treat for that IBD can be responsible for this renal manifestations, or the ongoing disease activity that could be a complication of IBD or extraintestinal manifestation of IBD. So I just want to discuss a few points regarding the renal manifestations and association with IBD. Yeah, IBD is a chronic relapsing and remitting inflammations predominantly affects your GI tract. Extraintestinal manifestation is apart from your GI, other systems to be involved. And the most common thing is like the extraintestinal manifestation has a range of around 25 to 40%, which affects both in adult and your children. Among all your extraintestinal manifestation, the renal involvement is more impairment are also a comorbidities when compared to other manifestations. So it involves like around 1 to 2% in children, where it reported to be 15% in adults. So that's why we are very keen on this. So I told like renal manifestation of IBD can be in many forms. It not only in a glomerulopathy, it could be like nephrolithiasis due to the metabolic defect and amyloidosis and your acute tubular injury. In pediatric population, it is more like IgA nephropathy has been reported and followed by the minimal change disease. So the balance between IBD and your renal manifestation, either the renal manifestation is independent of your IBD activity or dependent on your IBD activity. So independent in the sense this is an autoimmune disorder which has a disorganized immune system that lead to a renal dysfunction. Or renal manifestation should totally depend on your IBD activity. That is, even the disease activity will manifest in a different forms, and the immune complexes will target on a particular organ system, and that leads to a renal manifestation. Medical adverse effect is the most complication rather than the manifestation. So the drug-related nephrotoxicity, the most commonly aminosalicylates is a very good drug in treating IBD in very early onset IBD or pediatric population, which has a renal manifestation in the form of glomerular nephritis and minimal change disease, and followed by azathioprine, TNF alpha inhibitors, and tacrolimus also have a renal manifestation, but very less commonly we use in the pediatric population for IBD. So it's very simple thing to make sure that renal manifestation should be taken care of. So this is a recent article around like 2018. There were studies were done around like 456 children. Among like 44% of the child have isolated proteinuria and proven IBD, and 71.4% have IgA nephropathy in proven IBD. So our take-home message here is like renal involvement can occur in IBD, either the complication or extraintestinal manifestation. Drugs, the most important thing which are used to treat for the IBD, can present with a renal manifestation in any forms. So we are suggesting to have a urine routine even if they are asymptomatic. So there is no guided protocol to when to follow with the urine routine. So before you starting with any medications or treating for a IBD, or if you have a course of IBD, just to have a baseline urine routines, and followed by 3 months, 6 months, and 1 year later you can follow it. Thank you for the opportunity.
Thank you. Thank you. Stop sharing your screen, and we'll wait for about a minute. If you have any questions, please post in chat box. We are on time, just 5 more minutes to complete our question answer session. To the presenter who presented Takayasu arthritis, why ATT started for this patient? Is there any microbiological evidence for TB in your case of Takayasu arthritis? Is INH prophylaxis alone is sufficient, or ATT is necessary at this stage?
Sir, we hadn't started. We had planned to start, and we were planning to start INH prophylaxis only. There was no microbiological evidence for tuberculosis. There was only Manto positive.
Okay. False positive Mantos are reported.
False positive, yeah, it was false. We think in terms of false positive, and even if it was TB arthritis, there were been more of aneurysms rather than occlusions and irregularities.
Better to be on INH, as since the patient will be on immunosuppression treatment. Okay, so you are planning to start INH rather than ATT. That's it now?
Yes, sir.
Okay.
Yes, sir.
Thank you. And how effective is isoprenosine? On which stage of SSP it should be started? Next question. How effective is isoprenosine? On which stage of disease it should be started?
Yes, sir. So before answering that question, I just want to comment about the case. This is not the classic case of SSPE, which usually everyone sees, which starts at 6 to 7 years of age. This is the rare variant acquired because of the neonatal measles, which presents so early. So the youngest presentation reported worldwide is 4 months of age, 1969 in US, and this is perhaps the youngest age which has been which we have shown in South India. Probably others would have seen, probably not reported. So coming to the question, isoprenosine is an antiviral It also has immunomodulatory property. So it may stabilize the disease. Even the natural course of SSV, if you look at it, there is a 5% chance of spontaneous remission. Even without any treatment, there is a 5% chance the disease may stabilize on its own. So by giving isoprenosin, there is a possibility of stabilization in at least 35% of patients. That is what is reported in uncontrolled studies. There is no randomized controlled trial with isoprenosin or isoprenosin plus interferon or isoprenosin plus interferon with ribavirin. So coming to the question, isoprenosin, when do we start? It is best if we start in the stage 1 of the disease, which is prodromal stage. But as we don't have anything else to offer to the patients in otherwise also, we do start in all stages. But it's best to be start in the stage 1. If you start in the stage 1, there is a higher chance of stabilization when compared to starting in other stages. The dose is 100 mg per kg per day. And it is easily available as tablet Inociplex.
Is it costly or cheap?
It's not very costly, sir. I'm not sure exactly about the cost, but it is not as costly. Like it maybe per day treatment will come to 50 to 60 rupees per day.
Your personal opinion regarding the response to isoprenosin so far?
In this child, like if you see the worldwide literature, acute fulminant SSPE, they die in 3 to 6 months. Survive now, the child is now. So it seems isoprenosin has a kind of stabilized the child's condition. At least it has provided kind of a prolongation of life as well as reduce the myoclonic germs incidence. But definitely it is not a curative treatment. So we will, like every pediatric neurologist will start isoprenosin for any child with SSPE, whatever stage they may be in.
Thank you.
In addition to the supportive care and anti-epileptic therapy.
Okay, thank you. Thank you, dear. And
thank you.
Okay. And the next question with regard to Mycoplasma pneumonia causing encephalitis. So is it an incidental finding or accidental finding? What about the titer? How much, is there any rise in titer? Can we rely only on IgM mycoplasma to say whether the child is infected or not?
The rising IgM titers is diagnostic. We have not repeated the titers in this particular case. We did because as routine.
What is the value in your child? The value is not mentioned, I think.
Values.
Okay, leave
not mentioned, sir. Sorry.
Okay, well, at least you need to mention the value. No? Okay.
Okay. And regarding child did not have pneumonia, but 1 week back, child had history of URI. And for GBS evaluation, we are routinely doing mycoplasma IgM.
Mycoplasma unlikely to be present with coryza. That is the word is there in Wilson. Coryza is unusual in mycoplasma. Okay. No issues. And Ranjit has asked, have you done MOG and NMO antibody titers, CSF?
Actually, the child presented with the GBS picture and then developed ADM-like pictures, sir. And there was no involvement of optic nerve or spinal cord in the MRIs. So we did not consider MOG or NMO in this child.
So it is part and parcel of your setup to do a mycoplasma IgM titer in these cases, in demyelinating cases.
Yes, sir.
Sharat, Dr. Mahesh is also there. He may be able to say, like, you know, many neurological cases he does request because the mycoplasma presents with a lot of atypical neurological symptoms, and they need not have any respiratory symptoms even in the first instance. So kind of it's done kind of as a routine in many patients, especially when there is atypicality in the presentation.
Whether IgM mycoplasma alone is sufficient is the question.
No. So this is only a possible thing. See, we are presenting this in sort of in retrospect.
Even we had one case last month also. Yeah, similar.
Okay.
Okay, agree.
So this is only an association. We really do not know. You know, we know there was central demyelination and there was peripheral demyelination evidence. Mycoplasma was positive. We didn't really chase that up further to look for a rising titers. Child was better. I mean, probably in the future, we could definitely, you know, consider doing this, you know, having spent on so many things, we could probably just see if there's really something going on. So it's only an association as of now that we know. We don't know about the causality. Dr. Mahesh, sir, do you want to add anything, sir?
Yes, no, we do routinely do mycoplasma as well as GQ1B antibodies as an ecological diagnosis for GBS. So it's a sort of a routine thing we do in all patients with GBS-like presentation, number one. Similar to live serology in polymyelitis cranialis.
Have you tried antibody in the CSF?
No, Dana. We didn't do. No. And actually, incidentally, the respiratory viral panel does have a mycoplasma thing. So that was negative. PCR was negative.
Oh, okay. So it is very difficult to say whether
Correct. Yeah. But I mean, when we looked up, kind of in retrospect, there were multiple reports to say mycoplasma and this is associated. So we just
they say PCR positivity with antibody. Otherwise, rise in titer. If anyone is positive, then maybe.
This is sort of in retrospect, it was there, and that's the only thing we could kind of fit into the puzzle. Like there was more than one aspect which we wanted to highlight was the central and peripheral demyelination. More than the mycoplasma bit, the main idea of presenting this is, I was there at the time of receiving this patient. GBS with, he's just, I had my doubt whether he's alive when we received it. Like, there's this sluggish pupillary reaction probably was the only positive sign of life. So that was the idea. And first time we are seeing something like this, such bad cerebral edema with the GBS kind of presentation. And multiple brains have worked behind it. And it was kind of a puzzle only till the end, whether what exactly was it. But good thing was it was remarkably improved. And I should say that I think the most important thing in the whole thing that led to good outcome was probably the parental trust. 4 months, he's never questioned anything. Amazing. I have to say it, he's not part of the audience, but they really deserve mention here.
Yeah, we are satisfied with your answer. Okay.
Thanks, Sharat.
Every city there is one case of mycoplasma which is under query, so that's why we need to clarify.
Okay, sure. Then a question to you: unusual organism, unusual age. So MSMD is high on the cards, na, in this case.
But there are so many reports it can happen in immunocompetent also. So it is not like all the immunocompromised children are only getting. But as a part, just we want to rule out. That's why we send MSMD workup also. It is awaited. But looking back, it looks like an immunocompetent child only.
Okay, then thank you. So if you get MSMD workup,
here only the point we want to remember is usually for gram-negative meningitis, we used to give antibiotics for 3 weeks. But here the specific mention is minimum of 4 weeks they have mentioned. Even if you do a repeat LP, even if the LP is normal, the organism stays intracellularly. So you cannot assess clinically or microbiologically. So better to go for 4 weeks of antibiotic to the minimum. That's the point we want to mention. We had a long debate. Line was an issue, so we have to manage.
We need to learn the art of de-escalation definitely from your unit. The art of de-escalation. Okay. Despite having such a atypical organism, having de-escalating from meropenem to ceftriaxone, that's off.
Yeah,
we need to learn that art from you and your team. And question to us, I think the last question. In pulmonary hemosiderosis case, why there was a transient improvement in ATP? Nice case because the child was also started on prednisolone along with ATT in view of endobronchial TB. Maybe that course of prednisolone have worked in this case of pulmonary hemosiderosis, which was presenting with the cavity, manto positivity, and contact positivity. Maybe that course of steroids might produce some sort of transient improvement in this case. That is the thing that we had arrived in our mind. So is it okay for you, Kritika? The child was given steroids in view of endobronchial TB.
Okay, sir. Thank you, sir.
Okay. So I think with this, we are finishing our session. Nice carry home messages. Please do not forget to ask the history of rash in any case of neurological deterioration. Always in all cases of PUO, palpate, pulse, 4-limb pulse, which was not done. Disproportionate anemia with the pulmonary infiltrates. Think about idiopathic pulmonary hemosiderosis. Mycoplasma, which can present with the protein manifestations, Culture always matters. Inflammatory bowel disease again proves to be a multi-system disorder. So with these carry home messages, we are completing our session. We are damn on target. I need to thank ADR Plexus and Institute for Postgraduate Entrance Training, Dr. Arun Kumar Dayalan, who helped in the last minute to arrange this Zoom meeting. Without him, this could not be a possible one. And also thanks all to the audience, presenters, and the respective consultants. Thank you one and all. Bye-bye.
Thank you.